Next speaker, President-elect of ISMIS, Professor Zenya Ito from Japan. Professor, do you hear me?
Hear me?
Yes, yes. Hello.
Okay.
Nice to hear you.
Okay.
Welcome.
Okay, nice to meet you.
Yes, you can start.
Okay. Okay, nice to meet you. My name is Zenya Ito from Japan, and very thanks to be invited to the great conference. I'm very honored. So my presentation is the comparison of the laminotomy for lumbar canal stenosis with 4 endoscopies. No COIs. Recently, a less invasive method, percutaneous endoscopic laminotomy, was developed. We studied this clinical study in 2013. I would compare 4 endoscopy of MEL, FEL, PSLD, and UVL. The 4 methods differ in terms of working space, working length, and skin incision. The purpose is to compare clinical result of 4D completion surgery in patients with single-level lumbar spinal canal stenosis. All patients had spinal canal stenosis resistant for conservative treatment for 3 months. Exam items are VAS, ODI, EQ5D, operation time, dural puncture, dural rupture, and bone resection area, and facet angle. In only L3-4 level decompletion cases, L3-4 post-operative multifidus muscle was clarified by Gautier classification. As control muscle, we compare L2-3 multifidus. Their operated level relation, male-female ratio, and age average were not significant different. The MRI procedure is here. The outer ligament layer must be searched, and then upper laminar must be sufficiently. The contralateral hypertrophied sub can be quickly cut by a round. And this is a PSLD procedure. Also, we detach the ill ligament from the caudal side and detach the ill ligament. Also, UV procedure. We can use almost operation kit of open surgery using the kerosene like this and drills. And sometimes using the chisel like this. Result. Compared with preoperatively, VAS, back, and buttock pain was significantly improved by all 4 endoscopy surgery. However, there was no significant. Similarly, another items also significantly improved. However, there was no significant difference between 4 groups. The operation time, MEL operation time, was obviously the shortest. Next, the UVL. Then PSLD was moderate and FEL required long time. Dural rupture incidence was not significant different. The bone resection area in 3D CT was measured at L3-4 for each cases. UVL produced significantly smaller area than MEL. Ideally, the resection cut angle or bilateral superior articular process form a trumpet bell shape. UBL result in significantly more trumpet bell shape cut than the other two types of endoscopic laminectomy. Since MEL outer chest is wide, the upload side cut angle is minus, and it tends to be a reverse trumpet bell shape. In elderly, since many multifidus fat degeneration are already seen at the lower lumbar level, so I evaluated only at L34 with little influence on age. MEL has more muscle damage than the others. Discussion. As for the bone resection area and the facet preservation, MEL has a smaller range of instrument movement as the maneuver of surgical instrument. It's confined within 16 mm tubular retractor and limited tilting. In contrast, UBL has a high flexibility in maneuvering of instrument. In short, we can insert instrument under lamina. So the conclusion, how to select these four endoscopies. I select only one level decompression. I use UVE because the facet preservation rate is better than others. And two-level decompression, like including upper L23, like L2334 decompression, or L1, 2, and 2, 3 decompression. For keep the facet, I use a UV, but not including L23, like L345 or L45 S1 laminectomy. I use the MEL because the operation time is very short. And more than 3 levels, I use MEL because I use one level, one incision, and do the 3 level and faster operation time. And especially only recess stenosis, I use the PSLD under local anesthesia. That is my presentation. Thank you very much.
Thank you very much, dear professor. I have one question. What about the cost effectiveness? Which method do you think is much more cheaper and which is more expensive in Japan?
Okay, so most cheapest one is, I think, UVE, and most expensive one is MEL. So if the beginner in Japan for the endoscopy, I recommend the UVE because we can use the same items from the open surgery.
Thank you very much. Thank you.
Thank you.